Thank you, Rachin sir and Lakshmi madam for coordinating this. And thank you, Peridalmana Society for giving me this opportunity, Dr. Kunyamuddin and Dr. Mumtaz. So I'll move on to this typical scenario. An intrapartum patient having convulsion, loss of consciousness. The most probable diagnosis would be amniotic fluid embolism. Amniotic fluid embolism has always been a dreaded complication for obstetricians, and it was dreaded because it was always thought to be unpredictable, because we cannot predict when this patient will go in for an amniotic fluid embolism, and to a certain extent it was thought it was unpreventable but knowing the predisposing factors like oxytocins, use of ARM and oxytocin together, combined use of prostaglandins and oxytocin together, and use of smooth muscle relaxants. So knowing the predisposing factors and avoiding them has made us become a bit more preventable. And it was also thought to be untreatable because with a mortality of 60%, but with newer management protocols, again, the mortality has also reduced. Coming to the management, clinically, the diagnosis is mainly clinical. There is a Clark's diagnostic criteria which we can deal later, and the confirmation requires actually the actual Paka confirmation requires a fetal squamous cells in pulmonary vasculature, but usually we have to diagnose it clinically and that. And prevention is always better than cure. Be aware of the predisposing factors, and whenever possible, prevent an occurrence of amniotic fluid embolism, or if not, have an early recognition. Any patient who throws a fit, who is complaining of dyspnea in labor or soon after delivery, be aware of amniotic fluid embolism diagnosis. So early recognition plays a major role in improving the outcome. And aggressive resuscitation measures with high quality, that is actually it is that high quality CPR is needed in such patient, and she will require advanced life support and intensive care from a multidisciplinary team. And this patient, she has already delivered, but if the patient had not delivered, there is a role of perimortem or an emergency cesarean or perimortem cesarean. Even if it was just in the second trimester or after 24 weeks, there is a role for evacuating the uterus first and then going on for resuscitation. And this patient, as the history suggested, she had gone in for a DIC and postpartum hemorrhage. So we have to anticipate coagulation failure and immediately call for the blood and blood products, but also be ready to tackle postpartum hemorrhage. So what can we do to be that is collapse ready? We have to have a resuscitation trolley which has to be updated, as Dr. Pramila and Dr. Mumtaz has highlighted effectively. The ORRT team, that is a code blue team with the staff members, will be very beneficial in improving, that is giving the emergency care. We have almost completed the ORRT training in most of the labor institutions in Kerala. Then we should have written protocols displayed if and when it happens, what to do. Then drills and trainings should be conducted periodically so that everyone are updated and no one go into a panic when the situation arises. Arrange blood products even for a primigravida, even for a low risk patient. Better to arrange blood so that if at all anything happens, there will be availability of blood, and the multidisciplinary team is always important. And we have to remember that the escape diagnosis, that is for it shouldn't be amniotic fluid embolism, shouldn't be the escape diagnosis for any collapse. So we should have a definite diagnosis to go for. So this is the National Registry criteria, that is by Clark et al. Onset, that is any onset during dilatation and evacuation, labor, cesarean, or within 30 minutes postpartum, with the absence of any other confounding condition or potential explanation of symptom and signs. So actually, amniotic fluid embolism becomes a diagnosis of exclusion. So these are the classical findings: acute hypotension or cardiac arrest, acute hypoxia, which is defined as dyspnea, cyanosis, or respiratory arrest, or coagulopathy, defined as a lab evidence of intravascular consumption or fibrinolysis. So these three occurring in such a patient, we have to go for a diagnosis of amniotic fluid embolism. And so again, coming to the my conclusion slide. So this is actually amniotic fluid embolism can be managed effectively when we are ready to deal with a complication. And we have nowadays the literature says the mortality has come down significantly. So in the near future, maybe we will not lose a patient to this complication. Thank you, sir. So
thank you very much. You have brought in a very important concept also, that is perimortem cesarean section. In such a dire emergency, I think you don't require anything else, only a scalpel. Okay, you have highlighted that. Then again, you have highlighted that it's a preventable. No longer it is accidental thing which cannot be prevented. So preventable disease, then it's a treatable to a great extent. These are some of the changes which you have